I'll say, look, this is being interviewed. These are my personal opinions. Anyway, we're going live now, are we?
All right, we're good. We're live. Hi, Mike.
Wonderful. Hi, Steve, sir. How did we? And we meet yet again.
It's been a while, and look, I've been really looking forward to. I really want to introduce you to the people out there who haven't heard of you, but there's a lot of people that have followed your work in discussing the connection between the development of the jaw, the history of humans, which is one that I'm really interested in, is what we learn about the dental arch, the jaw, and what it teaches us about human history. And what we're seeing today in terms of how it translates to orthodontic treatments, and what is this connection between jaw growth, the dental arch, and how our kids are growing and developing. Mike, thanks so much for joining me today.
That's okay. Pleasure, Steve. It must be a bit early for you and a little late for me, but we're covering.
Yeah, exactly. The UK is a hard time. We're kind of in the last weeks now where the UK is before the clocks change, it goes the opposite way in Australia, and then it's nearly impossible for half the year. Yeah. It gets very dark here in Australia. Mike, we've been hearing this kind of conversation ramble for the last, probably decade. You were recently published in the New York Times in terms of your story, how you moved into discussing jaw growth and how it relates to dental arch formation. Can you take us back a little bit to where it all started? So you're a specialized orthodontist. Can you tell us how you began to think about where these these questions in your head about jaw growth and factors affecting people's and child's development of the jaw?
Well, Steve, I can't give a date on that, because remember, I was John Mew's son. My father had an office at home that he never used. He would always prefer to use the kitchen table. So after dinner, before I went to bed, I would often go sit at the table beside him from, a tiny age, listening to, and he would stop and he would talk to me, because he would always want a break. I'd come through. He would talk to me about what he was doing. And, he's a very engaging man, my father. And it became impossible not to be interested in this subject. So I decided to go to dental school at the age of 14 with a principle of doing this. I remember my best friend, I remember he had a retained baby tooth, a lower left E, if you know the terminology. And I remember saying to him, I'm going to become a dentist and I'm going to fill that tooth. To which I did, and I put a gold onlay on that tooth. And he then took it out with a pair of pliers. So there we go. But, I always wanted, it fascinated me. It didn't just fascinate me, but, I remember when I was even before I actually started doing orthotropics, I was just a dentist, even a dental student. And I remember, if I was at a dinner party and I brought this subject up, it would captivate everyone to the point where I'd actually have to stop the conversation and move it on to someone else. Because, as I say, the only people interested in what I'm doing are people with faces. If you've got a face, you're going to be fascinated, absolutely fascinated, because you're invested in this.
It's fascinating. You mentioned the human face, obviously, that is very fundamental to our species. And there was probably an earliest moment. I think might have been reading one of a paper or maybe one of a lecture that you did on the development of the face and the jawbones and the features, and there's connections there to how the human body grows and how nature grows in certain patterns. And there's this really interesting way that we transmit what we perceive in someone's face and what our body is telling us about the genes of that person. And so how people procreate and so forth is is heavily based on and communicate, obviously, the formation of the face. It's kind of very. This goes deep into our human psyche, which is probably what you were finding there, right? That people are connected to this.
Yeah. I mean, this is the sort of concept of mate selection. So, evolution was really, the person who really put the information into evolution was, of course, Erasmus Darwin, Charles Darwin's grandfather. He came up with many of the ideas attributed to Charles Darwin, not all of them. And, why was Charles Darwin on the Beagle going to the Galapagos Islands in the first place? He was there to prove the theory that he already knew, that his grandfather had told him about. What Charles Darwin had some really great insights, he was fascinated with the evolving embryos that taught us a great deal. And of course, he was also fascinated with mate selection. And that's where we're going with this. So why do you select a certain person? And, the information on this is fascinating. And I remember a study where they took wedding photographs and they cut them down the middle. And then they got women to order the men in order of attractiveness and men to order the women in order of attractiveness. And then they matched them all together and they more or less fitted. So in a way, we spend all this time talking about, I want someone with a nice personality. I want someone, who's good at sports or etc. But research consistently suggests that, yes, you're going to choose someone on these other reasons, but your primary reason is how attractive they are. And that overrides most other things. And of course, we in a way that makes us sound very shallow. However, in a way, I talk about, the attractiveness, health side, and it's two sides of the same old envelope. We're hardwired to be attracted to people who have grown well. Alpha Linney did some work on symmetry. Yeah, okay, that's wonderful. But there's more to it than that. And, they even did this study where they took young children. I think it was 12-month-old children initially. They placed these children on mothers' laps and put images that they could look at. And the children consistently looked at the more attractive face. Well, okay, you have to define who defined what the more attractive face was. Well, that's another story. However, they were so impressed, they did it with 6-month-old children. And these children can only just focus. So they've not really got many preconcepts. They've not been targeted by advertising or, social cues or whatever. And these individuals were still able to choose the more attractive face. And again, then when you look at the partners, you tend to see they line up. And I've always felt that your facial form is the CV of your health. You're displaying with your face that you're healthy. And that's then when someone finds you attractive, that whole attractiveness is health. So, and of course, it's a very controversial subject. Not so much now. Now, everyone that walks into my clinic knows just who I am and what we do. But if I go back 10 years before we'd really got going, people would walk in thinking that somehow I was an alternative to fixed braces. And you were going to have this treatment or that treatment. Both of them were like fixed braces. They did something to you. Parents would come in with their children and they would laugh at how crooked their teeth were. However, if I mentioned that I didn't think their facial development had gone perfectly well, I could have a sense of humor failure from the same person that was laughing how crooked their child's teeth were. And that, and I can understand, it's an emotive issue. How you look is so emotive. And I think in a way that's held back what I do, because a lot of people have looked at my results. I can remember a couple of professionals who said, well, you're doing no more than making pretty faces. I guess that's what all I am doing.
it is true that there's a disconnect there between, we see, crooked dental arches, and then it's not well known that, the dental arch sits in two bones in the craniofacial system, and that there are influences on these bones that that can have an effect on the outcome of whether a child develops crooked teeth. Now you mentioned that your father talked about this early, and he was very he is very kind of tuned into this idea that the face and the craniofacial form. Where did that come from? So like where was he?
Which element?
Well, like where did he because this idea isn't very well known. So
how did it develop?
Yeah, how did it develop?
So I think that let's go back in time. Let's go back. So my father can remember where he was in a car as a young boy when his father told him that he'd just bought the book of Weston Price's book. And that influenced my grandfather. And my grandfather was taught by Harold Chapman. And they were taught that at 4 years old, if you didn't have 4 to 5, I've discussed it with my father, you didn't have enough spaces between all of the incisors. So all of the front teeth should have about, enough space for half a crown that is about 2 millimeters. So if you didn't have that much space, you were going to get problems in the future. So my father would routinely widen people's dental arches. They had a program, 3 to 4 months of widening, 3 to 4 months of full-time retention, 3 to 4 months of nighttime retention, let go. And in that era, it was often enough to change the path someone was going on so they didn't need any form of, they were fine, they were fixed, they were cured, effectively. They went on to have perfectly straight teeth. That was the theory or the idea behind it. Now, my father orthodontics was his favorite subject, but he wanted to be a surgeon. He went on to East Grinstead, and he was working his way up through East Grinstead, but struggling with the exams because he was never an exam man. Neither was I. And his father then had a heart attack, so he went back to take over from his father. And what he noticed was that his father had been doing this expansion thing. Well, of course, Dad was in the era where we were told that this expansion really doesn't work. Don't bother, it relapses. Anyway, my grandfather had kept good records. My father then looks at his records and, takes out a measuring device. And, we spend a lot of time with measuring devices and with models, just, measuring about. And so he was measuring that intermolar width. Yeah. And he noticed that in most individuals, the relapse had occurred, but not quite as much relapse as he would have expected. He was taught that it will all go back, and yet it was only going back a percentage. Some individuals were completely stable, and some had widened even further. Now, that was an interesting subgroup, and he then set out to kind of think why. And of course, he came to the conclusion that if you make enough space for the tongue and the individual then puts the tongue on the roof of the mouth, it works. He then started thinking about open mouth postures and just looking at faces, and the penny just dropped in his mind. And I think that it's so easy. Once someone has had an idea and come to an observation, it's so easy to say, oh, well, that was obvious. But, he wasn't. You remember the days that other people had said this before. I mean, you've got Caitlin, was an artist going around North America in the late 1800s. And he, wrote the book, Shut Your Mouth, Save Your Life, I think it was. So, and he was coming to these conclusions because what he saw was the Native Americans and the Europeans coming in, and he was just staggered how different these groups were and why these groups were different. And he was an artist. He was spending a lot of time painting these Native Americans. So, and of course, Dad really, it wasn't as easy to get access to these people at the time as it is now. And of course, Dad really came to conclusions by himself on his own, and then he came up with ideas to fix it. And that's where he's been really unique, because I don't see many, if any, people around the world with a couple of exceptions, really getting consistent improvements in facial form. You know, there's a few out there, but consistent and dramatic, no, very few people. And that's what my father started to do. But of course, he was doing this 20, 30 years ago. And it was easier 20, 30 years ago. You know, you go back to the time of my grandfather, all you had to do is a quick burst of expansion, and that would often cure people for life. Well, when I was a school kid and I walked along the street pavement at school with my hands in my pocket, you know, lolling around, I could get a smack round the back of the head. You know, some teacher would come around and just clip you around the ear and you go, mew, hands out your pockets, stand up straight, hands behind your back. And of course, the fear of that happening again meant that whenever you thought you might be in an error or a teacher was, you stood up straight, mouth cut. But what would happen to a teacher who did that now? Probably be suspended.
I mean, times have certainly changed, and the you mentioned it was a little bit easier in your grandfather's time. You know, perhaps are you suggesting maybe that you know the malocclusions are getting worse or more?
I think so. I think so. I think it's notably getting worse.
So this is we're talking about two generations here. So I mean, that's really interesting. I mean, certainly in my lifetime, you know, I remember going to primary school, and there was probably 2 people in my primary year that had braces, and then as going through high school, you know, probably becoming a little bit more prevalent, maybe up to 10 in a bigger year. Now it's become much more prevalent. So we're talking about a space of 30 years here.
And the counter argument is that people just know it's available.
Exactly.
That is a counter argument. You know, we didn't have this available, we do now. You know, but it's difficult because it's not really entered the mind of the profession that this might be increasing. So no one's really trying to do a sort of reproducing cohorts to see if it's increased. My observation is it's increased massively.
I mean, I've found the same thing in patients. Looking at our pediatric patients, it's very rare to see a well-forming dental arch now. That haven't had any kind of intervention or so forth. But there's a larger trend here, isn't there? Because I remember going to an anthropological conference, and it was kind of my first real opening to diving deep into what anthropologists do, and there was a lot of dental focus there. I remember there was a lecture by Robert Corricini, and he discussed the hundreds of papers he looked at, and the very much overriding consensus of the conference is that these malocclusions don't happen. When you go back not very far in the dental arch, and once you go past 12 to 14,000 years, which isn't very long in the record,
not evolutionary blink of the eye, really.
It is an absolute blink of the eye, and it literally doesn't happen. They don't find them. And so when you look at this, when you take out, we've just talked about 2 or 3 generations, when you start to go back, further, you start to see that this trend is happening quite alarming. It's
really quite worrying what we're seeing, because of course it's not just malocclusion. If you allow me to philosophize on my views and opinions here, as a scientist should be able to do. I strongly think that sleep apnea, jaw joint problems, forward head posture, and quite a few of the ENT problems are all related to the same thing. So they're all, along with malocclusion, symptoms of faces that don't grow well.
And there's a lot of evidence coming out to confirm that now. It hasn't been around for a while, but recently there was studies published at Stanford talking about the flow of nasal air and the relation to the maxillary arch. But Mike, let's talk about. So we've talked about kind of your, you had this opening as a child, and we've got this this kind of trend towards, in human, the human species in general. What were your early perceptions in what we were seeing in with orthodontic treatment? Because the orthodontic speciality is a very, very kind of focused and difficult speciality to learn for people that aren't familiar with what an orthodontist learns. It's a very, very it's very mechanical. It's very, there's lots of calculations. What were your perceptions of this in terms of what you were seeing in terms of your training and what you're seeing in patients?
Okay, so so my first introduction to conventional orthodontics, we had a little bit at university, but when it really was here's how to refer patients to us and don't do this. That was clearly the training you got at university was just like nonsensical. It was around, this is too difficult for you, pass it on to us. Then in 1997, I started to work 1 day a week with my father. And then the rest of the time, I got a job working for a factory orthodontist, doing national health orthodontics. And he had a clinic where he just took on as many patients as you could in the local area, took on quite a few young dentists to do the donkey work. He would do the treatment planning, and we would just have a sort of factory orthodontic shop where you got 5 minutes per patient. You had quite a few staff, quite a good team around you, and you could work that five minutes a patient. The national health people, will accept that, and you could more or less get the job done in 5 minutes. See one patient for 5 minutes, 30 minutes for putting all the brackets on. And it was a hard-paced job, but clearly I worked there for 4 years, and I treated thousands of patients. And that gave me great experience in, what orthodontics does. And what first of all got me is some cases you would simply put the brackets in the mouth. You put a very light wiring. The patient would go away, maybe miss an appointment or two, come back, and the dental relationship, the way the teeth were, was absolutely perfect. You really thought you were the Mahuna of orthodontics. You had something special in you. And of course, this is the problem with young orthodontists, I see, because they start putting brackets in, everything goes well, and they think they're absolutely just the absolute dogs Mahunas, and they don't want to listen to anything. And they're taught at university that this is the latest technique, it's better than all the previous techniques. And finally, we've found the answer, which I'll come back to that issue. Anyway, I then found that that was about 10, maybe slightly 15% of the people. Then there was this other 20 to 30% of cases that just never went well. Didn't matter what you did to these people. And it wasn't always easy to predict who. I think I'd be better now. But they didn't go well, and their faces looked worse. And, it was quite obvious sometimes. And, whatever you did, the teeth never came together. You'd get asymmetries. It just wasn't going well. And, it fascinated me, but it also fascinated me. Luckily, the guy I was working for was very non-extraction, so he wasn't taking many teeth out. I worry where we're holding teeth out of their balance zone at the end with these appliances, and clearly I worry about that issue pan-globally. All these people their retainers are keeping their teeth straight, but they're holding their teeth out of their balance zone, which I just worry about. I don't think there's really easy answers for that. However, he was more ethical. And then I went back to university. So I went to Denmark. And of course, Denmark, is a very much more outside culture, tougher food, and generally facial growth was good. I remember I had 1 or 2 patients in my dental training that I thought, well, they're not growing well, that's not going well. Apart from that, much better response with treatment. Of course, I didn't do, we did about sort of 50, 100 patients. That was it at university. It wasn't a huge amount, but you looked into great more detail with them. But it was the education I felt was fascinating, because till that point I educated myself. I got some books. I was read widely, but I was working for an orthodontist and learning on the job. But now I went back to Denmark, at Aarhus, one of the top 5 orthodontic training programs on the planet, if not the best one for growth and development. This was the university where they took the gold standard for the European Erasmus certification. So, it was a great university, and they were really hot on their growth. But there was a lack of this coordinated thinking. I was asking questions. I asked more than 50% of the questions asked. Several times I turned around to my colleagues and I said to them, look, guys, do you mind? I'm asking so many questions. And they paused for a second, and one of them said, Mike, but you asked the right questions. And everyone seemed to agree. And one said, no, Mike, carry on. It's really helpful. You're asking all the questions we'd not thought of. But in a way, because I had a central structure, I understood what, I had a core belief. There is no core belief in orthodontics. The core belief in orthodontics are teeth are crooked, we're going to make them straight. That's not a core belief. And when you look at orthodontics, what we did in our training was we made a problem list. So we said, you've got this, and got this, and got this, and this, and this. And then we tried to make some sort of integration of the problems with the solutions you were going to present. Well, that is treating symptomatically. You're treating symptoms. You're admitting you're treating symptoms. And whenever I tried to ask causative questions, it seemed to go nowhere. And that's when I realized that the key to all of this was the etiology. The why. Why are teeth crooked? I said, why are teeth crooked? And people go, oh, well, because there's not enough space for the teeth. But why? Oh, the jaw's too big or the teeth are too large. But why? And, people hadn't really thought that far back. All the risks of permanent retention, all that faces might downswing during treatment because of treatment, possibly. And it was very mechanical. But Beate Melson had done her mechanics beautifully. She had taken the sort of Newtonian physics as applied to orthodontics, which Charlie Burston had really perfected, and she really worked it well. So we were doing clever mechanics. We never considered the forces of the tongue or the lips or the cheeks, which in retrospect was confounded the whole science they were talking about. They made all the science they were talking about just silly. However, such is life. And there were lovely people, the Danish. They really were lovely, and they taught me what they want. I didn't want to rock the boat too much. I sat there and I listened, but sometimes I felt a bit like Gorbachev, because here's a man who would come up through the Russian ranks, knowing one day he was going to try and change. He didn't really believe what he was doing, and I went through the ranks quietly in the back of my mind saying that I know that a load of what I'm being taught is nonsense, and I'm not really going to do any of this. I'm on a 3-year program in Denmark. That it was hard. It was a really hard program. I was in, and the number of nights I spent all through the night. I had some cushions beside my desk in my office, and I'd lie them out, have a power nap, get back on, carry on going. That was that type of university it was. It really restricted your social life there in Denmark. But in general, I just felt that I was on some sort of apprenticeship to learn how to move teeth. And I think that's what too much of orthodontics is. I had a lecture the other day, one of these sort of evening lectures we have that, all online now. So I attend more than I normally would. And it was someone talking about aligners. And she was an orthodontist, and she got her award for, the award for the best student of the year. And she was, down the line, trying to do the right thing, or following the rules. And what she was saying the importance, the half the thing was about what the patient wanted, where they wanted that tooth, how they wanted their smile to look. And, I reflected after the lecture, the whole thing was about putting the teeth wherever the patient wanted them. So in a way, orthodontics, or her version of orthodontics, which I think is what many people are doing now, is just trying to find out how the patient wants their teeth to be arranged and doing that. And that's odd in medicine. Medicine, we don't come up and say, well, so what's your aesthetic requirements for the position of your teeth? And then we're going to do it. No concept of the why they're crooked, what the health implications of doing this, the health implications of holding the teeth out of the balance zone, the fact that the teeth are in a balance between the lips and the tongue. None of this seemed to be considered.
When you, as a brief way to kind of give people an overview of the theory in orthodontics, obviously because it's a very heavy mechanical, you mentioned Newtonian physics, but the foundations, would you say they're based in angle? Would you say that's okay?
If you go back to the middle of the 1900s, or slightly before the middle of the 1900s, you've got people like Frankel in East Germany. You've got Planus in Spain, but of course he's in Franco's Spain, so it's a little bit difficult. We're not. We forget, even not that long ago, we had really difficult. We didn't have the European Union. We didn't, lack of integration. My father actually went to travel to see Frankel in East Europe. He crossed the Iron Curtain to do that. And thinking it would be a nice jolly, he took my pregnant mother with him.
Wow.
They turn up to this the border control, and they land in the airport, and they put him in some Nissen hut for the night. They just put them in the Nissen hut and said, "Oh, you wait here." Let them out the next day. And there's one chair, and my father let my mother sit on the chair, and she's pregnant with me. So I guess that means one day I'll be the oldest person who have crossed over to see Frankel. However, and there's also Andresen in Sweden, and I've probably forgotten a few really important names here. But however, you had these various different charismatic individuals. Now, let's just take Angel and Frankel. Well, Frankel was making these appliances that held the lips and cheeks back. And if you use the lips and cheeks, it would be uncomfortable. So not only would it change the balance zone, so the teeth became straight, but also it would inhibit the use of the muscles, so it would train you and hopefully gain a permanent change in you. Angel was taking a mechanical perspective of forcing the teeth into position. Okay? So now, you think about it. You've got either you're going to take young Johnny and put this painful appliance in his mouth that's going to treat the causes of the symptom, or you're going to physically move the teeth into the right position mechanically. Well, okay, you've got parents who are paying to have the teeth straight. That's their end goal. And also, if you're trying to make a business based on uncooperative children, then avoid the complex appliance. So who's won? Well, Angel, clearly, because it's the fixed braces. Fixed braces are everywhere. I had a patient from Berlin recently, and he could not find anyone in Berlin or the surrounding areas who did Frankel appliances. And that goes to show, even, okay, that's Berlin, a bit north of where Frankel was, but even in the cat country where Frankel came up with his appliances, it's hard to find anyone who does it. And yet, fixed braces are to a penny everywhere. So we've selected to make the teeth straight, push them into a position where they look nice.
Do you think, so that was early in the 20th century. Do you think there are any other kind of pivotal, influence or studies that really, because the mechanisms we use today popped up in the 50s and 60s, That'd be about right.
Well, I think the big thing that changed fixed braces was the work of Andrews with the pre-adjusted bracket. So what Andrews did was, so previous to Andrews, you put the same type of bracket on every tooth. The thing you stick to the tooth was identical. Well, if you've got front teeth or big fat canine teeth, well, clearly you want the wire set further out. And you've got little things like your little laterals, tooth number 2, you're going to read the wire set further in. So there was an enormous amount of wire bending that had to be done. And of course, you only had steel wires. So if you had to make a significant move in a tooth, you couldn't just put the wire in because it was too solid. So you needed to take the wire up, make a little loop, come back down again, through that tooth, go up again, make a little loop, come down again to the next tooth. And that then gave a little bit more flexibility to the wire, so it wasn't too aggressive and harsh on a single tooth. Now, that was a real skill to bend those wires. And I've heard tales from these old wire benders. I remember someone telling me that they had a technician in this one clinic that would do all the preparation, the wires. So they had a standard treatment, standard kind of design, and most mouths are quite similar. So she would make wires in advance. And she could bend these wires up in 5 minutes, put one down, and it would sit perfectly on top of the previous one she'd done. And she'd made a stack of them and they looked identical. I mean, gifted. Anyway, along comes Andrews. Andrews realized that most canines are this, X thickness. Most laterals, tooth number 2, are Y thickness, and most centrals, front tooth, are Z thickness. So why don't we simply make the brackets different for each individual tooth? Then you put a set brackets on and you put a straight wire through. So no bending required. And of course, then we had these NiTi, these super flexible wires turn up. And all of a sudden, orthodontists just took off. And of course, at the time, orthodontists suddenly started making a lot of money because clearly now you could do the same thing in a much faster space of time. People are starting to worry about their aesthetics more. So you're making more money and you're getting more patients. Then everyone wants to get into orthodontics all of a sudden. It had been a 1-year postgraduate master's. All of a sudden, it becomes a 3-year postgraduate master's, and you need to get your fellowship of dentistry to get into it. I mean, crazy. You needed your fellowship to go into surgery previously. So all of a sudden, the brightest are going in to do orthodontics. And this is one of my problems. One of my problems is when you get the brightest, you have a bias towards calculators and photocopiers. So those people who are human calculators and photocopiers, well, they do very well with exams. And when you set a very high exam as a barrier to entry because there's something to be desired, like a lot of money to be made, then you tend to find you will selectively get a lot of photocopiers and calculators. And these people are brilliant at taking in information. Literally, photographic minds, they absorb it all. But he who absorbs all this information isn't going to think about what they've learned as much. They're not really trying to understand that information. And I think, and then, then you defend what you've learned. You will defend what you've learned to the hilt because that's what you learn. And you learnt it. It's only idiots like me who struggle to learn it, who try and gain it, get that information by making a central philosophy that I can hang the information on. Because I need that. I need a central philosophy to hang the information on. I'm a crazy dyslexic. You need to memory hook things. So you need to make a central philosophy that makes sense. You can't have this sort of Bible of instructions. And that's what I worry too much within orthodontics. We have some Bible of instructions, and it's become very much more a religion than a science. Where do you have a science where, the wrong people aren't allowed to speak? You're the wrong person for this conference. Where do you have things like people are vetted? You don't have vetting going on in a science. Anyway, Steve, by the way, I noticed we're getting quite a lot of questions arrive. I didn't know if you wanted to tackle any at some point.
I think we will pull, because we've kind of, I was just thinking, you know, we've kind of spent 40 minutes on the philosophy and a little bit of the background.
Yeah.
I was thinking that we will definitely move into a little bit more of the, you know, what we see in the mouth, you know, what parents are experiencing. You're a father yourself, so you're experiencing this firsthand. I've got 2 young children now. I'm seeing my son's dental arch is his primary dental arch.
How old is your son now?
He's 2.5. Yeah.
Okay.
Yeah. So
well, I think my early entry point is that, you know, with that, I think that most myofunctional therapy can be summed up or can be grasped, you know, the low-lying fruit. What do you want to do to get the most butt for your myotherapy? Eat with your mouth shut. Lips together. Lips together when you're eating. Get your kids. So at that age, you know, this is the age where habits can become lifelong habits. You know, you can ingrain a habit for the rest of your life. And the best one is elbows off the table, sit up straight, eat with your mouth shut. That's huge. The difference between doing that and not doing that are just huge. But I know it's not easy. That's what I've learned. It's not easy getting these things done. You know, it's easy to say it, but not saying. You know, I've got I've got, you know, at least I have the backup of, I've got a clinic designed to make these appliances. You know, I laugh sometimes. You know, I remember coming back, absolutely pie-eyed drunk, trying to get a brace into Zarina before she goes to bed, and I'm swearing at this brace and thinking, well, remember, Mike, you designed this brace. If you can't get this into someone's mouth at this in a dark room, then who can? You know, spare of thought. But it is another, when you start actually having to do it, you realize that it's on your children. It's taught me a lot. You know, it's made me a better practitioner by having children and trying to influence their growth.
You really, I mean, as parents, you really do experience how difficult it is. And yeah, this whole idea of altering habits and altering, you know, and even sleep habits, you know, it's, you know, because the big thing that I'm talking to patients a lot is the mouth breathing and trying to redirect that. But you know, the application of getting a habit like that to change is incredibly difficult. So you really have to kind of feel for parents out there that this is a problem it's not easy, is it? It really is. No, it's not easy.
I mean, I think the one that has worked a couple of times, I've seen some examples where, and from 4 years old, I've got people chewing gum. And I've seen some stunning results from that. You know, but from 4 years old, I highly recommend everyone starts taking decent quality side lateral photographs of their children every year. I think that should be, if any dentist is watching this, that should be mandatory. If you're a dentist seeing growing patients from 4 years old or above, take an annual lateral photograph. That's a minimum. You know, if you hear me here, and I ever run into you and I hear you haven't done that, then the minimum standard of care.
Well, let's talk a little bit about the growth and development. So we've mentioned, you know, a 2.5-year-old and a 4-year-old. So can you describe to the audience what's happening in a 4-year-old's mouth that we should be thinking about the side of their face, and what are the factors influencing it?
Well, okay, so we clearly this is getting on to what causes craniofacial dystrophy and then what goes on. So, you know, what we've done is we've thought hard about this. We've come up with this term craniofacial dystrophy because no one's nailed the fact that there's an underlying problem. So that's what I realized some years ago. I said, you know, having understood that we've got to understand what causes the problem, we then have to understand the pathological process and why these things start going wrong. Okay, so if you've got a 2.5-year-old, what could have gone wrong? Well, the two biggest things are, of course, the toughness of the diet and the oral posture. Okay, Now, I would bow to you on the constituents of the diets, the things in diets that might be affecting these things. It's not my area. I'd love to get some good evidence and know what to recommend to people. It's not my area. However, it seems that disruptions in things like breastfeeding, okay? Now, and more I'm looking at this, I'm thinking we're needing exclusive breastfeeding for prolonged periods of time. So that means nothing but breastfeeding. And as soon as you start adding non-breast, anything but the breast, that's where the rot sets in. And you would be really good. I mean, we breastfed both till me didn't do any breastfeeding, but we breastfed for 14 months for both of them. And it was pretty near exclusive till about 6 to 8 months. I was trying to hold back, but clearly that didn't happen. And then it's then all these nasal congestion. I see so many kids getting blocked noses at young ages. Just, it seems almost normal to have a fundamentally blocked nose in the first year of life, to the point where it may last 1 or more days. Now, what are you going to do? Because either you die or you start breathing through your mouth. And when lowering your tongue and opening your mouth is neurally linked to such a panic that you would have died otherwise, that's a big learner. That's a lesson learner. When we're talking about you can't gain habits, you can gain an open mouth posture pretty easy. Just getting a blocked nose. And my worry is that this is when kids are actually learning to walk. They're learning to walk and they've got a blocked nose. And this is, how's that impacting someone's lifelong progression?
I noticed in my daughter, who's now 1, she had she hasn't been sick very often. But she had a cold, and she's got she was exclusive nasal before that. But I noticed in that time you could see that she went to the mouth, and it was a process to push her back to the nose once the day. It was about a day of the bad nasal congestion, and then she had to kind of sniffle through it. But we had to. She was breastfeeding at the time. We had to kind of take her through a process in order to get back to nasal breathing. And it really kind of stuck with me. I was like, well, if you don't really, think about that and, make a concerted effort to influence the child to breathe through the nose again, like that's potentially, habit form, as you say. And it's really interesting, the posture and walking connection. I think that's a really important point. Yeah. So what would you say for parents out there, because this is a really common problem, what would you say for kids with nasal congestion? How would you tell parents in young kids, because obviously young kids are hard to intervene in, what would you say to parents in terms of a strategy as to what you've done with your kids at home, but also how you educate your patients? How do we get kids getting back to breathing through the nose?
Okay, well, breast is best. Of course, if you've got a mouthful of breast in your mouth, you're not going to mouth breathe. And that is the single best thing to change your habits. I had an interesting experience with number 2, Zarina, when she was she got onto a dummy. I mean, clearly, it wasn't my choice, but she got a dummy. I then forced her off the dummy at about 18 months, 2 years, maybe a little bit later, I think. And what I noticed was she was a much better at nasally breathing when she had the dummy, but pacifier, as you would call it in the US and other places. But, we would call it a dummy. So the pacifier forced her to nasally breathe. And that was quite counterintuitive. And then when I think about research using pacifiers, maybe that's why breastfeeding or pacifiers or bottle feeding, they don't show up. I'd love these to show really good black and white answers, and they don't. And I think it's just a little bit more confounded and complicated than that, where the way that if you use a pacifier, it's going to force nasal breathing, which is actually beneficial. And that's one of the reasons in this area, you don't see the research coming up quite as trumps as I would like it to. So it's just a little bit more complicated. And, I hate that term, we need more research, but we do in this area. Well, we need some research. I think that people have been coming this from some very interesting angles, but before we really understood that malocclusion is a symptom of something else, it means a lot of the designs of the studies we had before don't hold up to the light as well.
Mike, Frederick has asked, you mentioned 6 months, but so he's asked specifically, how long do you think you should breastfeed, and when you can start to introduce food, and what can you start to introduce? How do you feel about the baby-led weaning program?
Oh, yeah, I'm very, very pro baby-led weaning. I think that's excellent. I think that my suggestion, but the thoughts on this are trying to piece things together is, well, when babies reach out, grab something, they will inevitably put it in their mouth. And this is going to happen from about 6 to 8 months. Now, at that point, you could start introducing them food as a novelty item. Okay, so what you do is you get carrot sticks, you follow the baby-led weaning principles. I'm no expert on it. But in a general rule, you cut the slices up so they're 1.5 times, which is 1.5 times the size of the baby's palm, so that if they pick something up, is likely to stick out one side. And you then leave them. And what you do is so whenever you're making the veg for your meal, you cut some of the same veg. You either don't cook it at all, or you very lightly parboil it, and you leave that in front of baby. You just put a pile in front of baby so that baby can identify that you're eating the same thing, which is important. And it's not force-fed, this stuff. The stuff's there on the plate for what it wants to do. It can throw it on the floor. It can have a nibble. You're not really worried if the child is going to get any nutrition. That's not your objective at this point. And, I've heard constantly hearing people back go, oh, we tried baby-led weaning, but the baby wasn't eating enough. Sorry, they've got the breast. They're going to take full nutrition from breast for a long time. And food is only a novelty item to have fun with. And that gets you the right attitude to food. And it's going to be solid bits of food that you actually have to chew. You're not, this time is you're not trying to gain your calorific loading for a child through a hand food. That's breast. The breast can provide everything you need. This is just some fun, getting used to food. And then you gently provide more and more food. Everyone's going to be different, but you follow the principles of baby-led weaning. You try and give tough stuff. And then you check the nappy, because nappies are going to tell you how much is actually getting through. And if you're a breastfed baby, you can very clearly see what didn't come out the breast, can come through the breast. And when you feel there's enough of that, you can then start cutting down on breast and moving further across. But I would delay that for as long as possible, but in 10 to 14 months, if possible, before you're really significantly increasing the amount of non-solid, significantly relax, the breast. But remember, I'm not an expert on this area.
Yeah, I mean, looking at the World Health Organization,
I have to say after every comment these days.
Well, I mean, but these things, we know these things relate to jaw development, so it's good to kind of have a general guideline, and obviously people will go to their professionals for their opinions and so forth. Okay, and so look,
I've also with young children, and I did this myself. The first thing that I did with children is really trying to reduce the potential of allergies. So it's the other thing so we had all the windows open for the first couple of months, and the heating on, because I just wanted to make sure it was summer as well. So, and there are some issues, I talk about, you shouldn't, or the Buteyko with Patrick McEwen makes a point that you shouldn't have the radiator on and the window open, because that can really dry your room out and your nasal passages. However, just getting fresh air in, I thought was really important when the kids were young. And I had my leaf a day complex. So whenever we went out, I would take a random leaf from a bush and put it in my child's hand. And my thoughts behind that, you're just building up bacterial loading from the grasses and trees, which is where we miss too much bacterial loading these days.
It's a good point in terms of the connection between the immune system and because obviously a very, very significant aspect of the immune system is housed in the nasal sinuses.
Yeah.
Really
important. And I think there's the research coming out suggesting that if you breathe through your nose, it reduces allergies. If you breathe through your mouth, it increases allergies, because all of these things have to be presented in the right way. So if you breathe in, let's say you have a certain allergen, allergen A, if you breathe in allergen A through your mouth, it turns up in the body and the body goes, what the hell's this? Never seen this stuff before. There's no report on allergy A. Let's set up a bad reaction to this one. Whereas if it comes through your nose, it gets processed. It gets registered. And people say, well, you breathed it in. Well, yeah, clearly this is stuff that exists in our atmosphere. Well, we'll note it down as possibly existing in the atmosphere. Don't take too much notice of this. It's around.
The understanding between the immune system and respiration, through the nasal sinus is pretty well established now. What's the connection? Can you explain the connection as the child's growing to breathing through the nose and developing that bone, that maxilla, the upper jaw?
It's in what respect, Steve?
Well, so we've said that nasal breathing is important. Why is nasal breathing physically important for a child for their jaw to develop?
Well, okay. You can breathe through your nose or you can breathe through your mouth. And if you're breathing through your mouth, then your tongue's not on the roof of your mouth. Point blank. And having your tongue on the roof of the mouth is vital to growth and development of the maxillary complex, I believe. I think all the evidence says this. But so it's vital that you have a patent nasal airway and you use it. There are two types of people who have their mouths open. Ones who are actually breathing through their mouth, and the other ones who are actually breathing through their nose, but their mouths open. And so just where the air goes is not that important. It's whether the tongue is on the roof of the mouth and the mouth's closed. Because then the tongue is going to be occupying its space. I often say it's a little bit like, you see people with a great big tumor in their bone. And this is a solid tumor that's sort of grown out here. And when you actually open the tumor up, it's just full of fluid. And what's happened is this cyst has gently expanded, but it's got very little pressure. And yet it's carried this bone growth all the way out here. Well, if you have your tongue sealed in your mouth with your teeth together and your lips together all the time, your tongue will gently expand this area. And that's how the face should grow. And you see these maxillas of our ancestors. They're huge, great big maxillas.
It's the tongue's it's a difficult, organ to kind of understand, when you really look at it. And
yes,
it is something that, so in my dental training, we didn't get a lot of kind of functional understanding of the tongue, besides, what it generally does. And then there does seem to be this whole world around, how important this tongue is. And we'll really, really jump into that. So we've discussed this kind of earlier stage of childhood growth and development. A lot of parents now have found that, they weren't quite, cued into exactly what was really influential to grow their dental arch. And they're finding now at 4 and 5, when the primate dentition, is all erupted, that they're noticing issues. Can you describe some of the signpost symptoms that parents will see in a 4 to 5-year-old that potentially the growth isn't quite heading where it should be?
You go back to Harold Chapman. If your child is 4 to 5 years old and there are not large gaps between all of the upper incisors, they are going to have problems. in the future, in my opinion. And, that's a sign to look out for. And that's a worrying sign. What happens to me frequently is in those cases that aren't quite as severe, parents come in at 10 or maybe younger, sort of 8 to 10, and they said, but the teeth were so lovely in the baby teeth. The baby teeth were perfectly straight without gaps or anything. It looked beautiful. They've got no idea that that's completely abnormal. That in the baby teeth, you should have huge, great big gaps. The teeth should be well worn down. And you should have this big, broad smile. That is normal. That's what you should want to expect. And if you've got, no gaps between the baby teeth, you've got big problems coming on, because the next teeth come in crooked. And remember, these are signs. Crooked teeth. Well, I mean, yes, I'm an orthodontist. I'm supposed to care about crooked teeth, but I care about faces, the way faces grow, the impact on health from a well architectured. A face with good architecture works well, and all the functions associated with that face work well.
Can you describe some of the patterns we see in kids that are, so you mentioned pacifiers, and so what happens to the bite? And I'm seeing a lot of primary dentitions now with malocclusions as well. Have you noticed an uptick in that?
Oh, yeah. I've noticed an uptick in the severity of everything. I think this affects what my father was doing, because, my father was getting really good results in the 60s, 70s, and 80s. And I think they started to deteriorate in the late 90s. And because he was doing the same thing. And the ground's now moving. As I said, I was walking down at school, someone would slap me around the back of the head. Then, of course, we had tougher food. The amount of added sugar in food is going, where are we at the screen? Is that the right way? Going up like that. And it's crazy, because every easy calorie you get, you're going to need one less hard calorie, unless you're going to put weight on. Now, clearly, a lot of people are putting weight on. But for example, so I could probably get 750 calories in here. Some cream, marshmallows, a bit of syrup, nice hot chocolate. Couldn't touch that sort of stuff myself at the moment. However, if I did that, that could be a quarter to a third of my calorific intake for the day. Now, if I'm going to take that many calories in with no masticatory effort, nothing, then I've reduced my masticatory effort for the day. And then that's very prevalent. And when you watch so many kids these days, they're having a good chunk of their calorific intake is so easy that they don't have to chew at all. And that's reducing their overall masticatory effort for any given day. Then, of course, I'm watching them. There's no imposition. No one's even telling them to sit up straight, shut the mouth. Everyone else is sitting with the mouths open. So the reflection, their mirroring is not helping. All in all, there's a big issue. And it's getting worse. And, when I give a lecture, I'll often show an image of Spandau Ballet. Now, I give this image because Spandau Ballet, they're now 60 years old. And I was told, and I remember saying this at a lecture, I said that, we're now predicting that people who are 10% of people over 60 are going to die 10 years early because of sleep apnea and its consequences. And I think this is because they've got craniofacial dystrophy. Same thing that's causing malocclusion. So if you've got bad malocclusion and you're lacking several teeth, you are likely to go on and get sleep apnea. Now, I remember asking a couple of I saw a sleep guy on Monday, and he said, Mike, that is a gross underestimation. Gross underestimation. And now, when we wind that group back, the people who are 60 now didn't have as much crooked teeth, from my observation. So what's going to happen to the kids today when they're hitting 60? And how badly were they affected by these other comorbidities? is looking very scary. And, you know, to the moment, the tide's turning. Well, of course it's going to turn, because people are going to start asking, what the hell is going on? You know, people are dying young from sleep apnea, and a lot of people. And I think it's related to craniofacial dystrophy, crooked teeth, forward head postures, many ENT problems. And I think the list could go on so much that it sounds unbelievable. But for most people, no idea that this is even an issue. And it's getting worse and worse. It's getting worse at a rapid rate. You know, when I was in dentistry, so I qualified in 93, a year late. And but I had a good time. And we talked about sleep apnea was mentioned once, and it was called nocturnal positional sleep apnea. And these were the guys who were getting right side congestive heart failures, and their lungs would fill up with fluid at night. So you would prop them up so this didn't happen. Now, that was the only time sleep apnea was mentioned. And that had nothing to do with the type of sleep apnea we recognize now. That was a cardiac condition. So basically, it was flying below the radar when I qualified in 93. And we've got to the point now where more than 10% of the people over 60 are dying more than 10 years early because of sleep apnea and its consequences. I mean, whoa, that's caught up quickly, hasn't it? That's been a sea change. Where was sleep medicine? It didn't exist. There was nothing. You know, when I went to Denmark, I had to spend some time in, so I qualified from Denmark in 2004, so 10 years after I did my dentistry. And I remember nearer the end, I went to spend 2 weeks in a ENT department. And I came to London because it was easier to do that and make a holiday out of it. And I remember they had a sleep department at the London hospital, and I asked to go and visit it. And I visited a nice Australian woman, actually, who was a nurse, OT, I think, was running that at the time. And I went and visited the unit for the neonates and the young kids to look at, they've got sleep apnea. And it was all new. You know, I'd never seen this equipment. I've never seen this type of setup. Well, now every hospital's got a testing center for sleep apnea. And this is rapid. Don't you know, you stand back sometimes and look at these patterns where they're going. And there's going to be no way people will not know this. Because it's going to get to the point where, you know, you get up to 30% of 60-year-olds dying early from sleep apnea. And someone will turn around and go, well, whoa, wait a minute. What's going on? What's causing this? And that's what we need to know. And that's what we need to start asking those difficult questions. But unfortunately, that is going to require systematic change in medicine. And who wants systematic change in medicine?
The rise of sleep apnea, I think it does really kind of show the disconnect between the dental faculty and the medical faculty, because the probably the awareness of sleep apnea has seen a rise due to dentists becoming switched on to diagnose. It's very simple to see improper breathing patterns in the mouth and so forth, but it probably does highlight that, you know, this disconnect between how dentists and medical practitioners do, for a large part of their career work separately. And, you know, this idea that craniofacial form that is, you know, very much, you know, in the dental sphere is influencing how a child and then an adult breathes. It really does kind of, do you think, I mean, we're talking about a multidisciplinary approach here. And, you know, it's something that is a challenge all over the world where practitioners are a bit isolated in that sense.
Yes. I think, you know, let me get it right. So either I am right in what I'm saying, hook, line, and sinker, or I am completely crazy. You know, maybe I'm absolutely screw loose and I'm just remarkably stupid. Or I'm right. There's no two ways. It has to be one or the other. Now, if I'm bark raving crazy, well, I'm kind of, I'm kind of enjoying my craziness, so I will continue. And if I'm right, well, then I very much need to continue. But when you stop and you reflect back on the implications of what I'm saying, it is going to bring so much more value to the dentist. This craniofacial dystrophy is going to put the dentist in a real driving seat within the team that is going to have to re-evolve around this problem. Because as I said, it's only going to get worse and worse until people start realizing, as I said, Steve, another way I start lectures is I talk about the fact that if I got run over tomorrow by a red London bus and I was to gain an accident, I get run over and I get hit, I could have an injury that 100 years ago I had a 95% chance of dying from, that I now have a 95% chance of surviving from. And that has been an incredible change. We've got the bacterial theory, the knowledge of bacterium. We've got antibiotics, anesthetics, surgical techniques, and the list then goes on and on and on and on and on. And it's amazing what we can do. So with acute medicine, modern medicine has been brilliant. And I mean, it's important we don't forget that when we can be critical of medicine at times. Because medicine really has got acute medicine down to a fine tea. However, if you have a chronic disease, and that's not a natural chronic disease where we're all going to die of something, then one could argue that modern medicine's failed because they can't cure the disease. And in most of those situations, you could relate a lifestyle challenge. So you could say that disease is related, or those chronic diseases are related from the dislocation of how we live today from how we used to live in the past. How we evolved to live and how we are living. So our lifestyle. So most chronic diseases are related to lifestyle challenges. And that means you've got the lifestyle and you've got to change. People don't like changing. That's half the problem here. That's half my work, is trying to get people to change. I frequently say to people, if I could plug into the back of your cerebellum and I could sit there, I got a big computer processor and I bang it all up and I tweak some, lines and I get some buttons and I'll go, right, you're cured. I'd press upload. You'd walk away with perfect posture, and slowly over time, you would improve your structure. And that would become a reinforcing cycle, a virtuous cycle of change, and you'd be better. If only it was that easy to change people. If only it was. We could upload a foreign language, some algebra understanding. That's not how things work. Life's about learning it for yourself.
I think that's a good point, especially with health, is that, a lot of patients, that they go to practitioners thinking they're going to get this silver bullet, or, they're going to, and it's just
I've disappointed a few people.
and you make a good, kind of separation there between acute and chronic disease, where acute medicine is based about this, kind of, a silver bullet as such, but a chronic disease or a chronic condition really does require an entire focus on how a lifestyle is contributing to a condition. Would you say that craniofacial dysmorphia is a chronic disease? How would you kind of classify it in that sense?
Yeah, it's a chronic disease, clearly chronic. I mean, I tend to call it a syndrome because there's so many things related to it. I think that, finer minds than mine are going to come along. We need some photocopiers and some calculators to come along and add the detail, and add, because, is it a disease? Is it a syndrome? But it's definitely chronic. You see these problems, fixed braces or fixed retainers, permanent retainers. Well, that's an answer to a chronic problem. You can't have a situation where you have indefinite something.
It's true. And as we said, the rise of sleep apnea certainly seems to be a consequence, something that I'm seeing in kids more and more, which is just, it's just really alarming that we're and parents really coming in quite distressed, that their child isn't breathing well at night. And, you can see
that should be mandatory. I mean, if you are a parent, you must go in to see your child. And I recommend somewhere between 90 minutes and 2 hours after they've gone to sleep. Because then when you count the phases, then they're in a phase where you can get a good predictor of they should be whether sleeping or not. And you can use there's loads of programs you can get, if you've got a phone, you can get these programs to measure the sleep noise. You can do it for yourself. But, my goal here is prevention, Steve. So, anything we can do to prevent these problems from happening in the first place. That's why you've got young kids, get them prevented. You know what's at stake here.
The two solutions for sleep apnea currently are the CPAP or the mandibular advancement splint. And you mentioned prevention, but so Michael asks, is there a window of time that people can prevent sleep apnea or techniques, or
window of time? That's interesting. So that Jesuit phrase, give me a child until they are 7 and I will give you a man. Bit sexist, Jesuit phrase. I think that it is so much easier to get in there early. So before 7 years old is really vital, because that's when people build up. It's very easy when you're that age to build up a habit that can last a lifetime. And, that's vitally important. Now, that, I guess, using certain techniques. Yeah, certain techniques. So let's go through this. So I think that I made a big list the other day. When you're young, having a fit mother with good abdominal strength, I think, is important. I think that's something we're missing because we've got so many parents that are older. I'm not making judgments. People are older. They'll have lower abdominal muscle tone and they're sitting all the time. I'm looking for avenues that could be affecting congenital issues. And I see there are lots of kids born now who have got malocclusion when they're born. Why? Crumbs. That doesn't totally make sense to me, but I've got to, I've got to face the things I don't find easy. Then we go through, as I said, baby-led weaning, breastfeeding, hard foods, breathing through their nose, lips together, standing up straight, mealtime exercises, onto chewing gum, lip taping. These are all the things you can do sort of without treatment. Okay. Now, at 4 to 6 years old, I'll often do just what my grandfather did with a burst of expansion. With some training, with some tough chewing, we have a year's program, a year only, to see if we can nudge people in the right direction. It can be helpful, but these days I frequently find they will need further treatment. Usually lesser treatment, but they will need more treatment. Then at sort of 6 to 8 years old, I can start conventional classic orthotropics, depending on the situation. 7 or 8 is usually a good age. Depends on the presentation. Then as you start getting the wrong side of 10 years old, then I start needing more treatment and more motivation from the individual. And when you turn, and with what I dislike the most is a sort of 14-year-old plus that come into the clinic and they've been told that they've been seen an orthodontist who will say, we're going to take teeth out. So they've hunted around, they've found me, and they've turned up to see me, and they're going to say, oh, well, when are you going to put the brace in that's going to make me better? And I'm saying, well, you've got to work hard. And they go, of course I'll work hard. I'm there. Yeah. And is that great? You know, I had a kid in, he was actually 15, and he parents took him to an orthodontist. They said he was going to have to take out 2 upper teeth, pull the rest back. He found me online. He dragged his parents along, and he is literally, yes, sir. What else, sir? Yeah, I'll do it. Do it up. Chew these, chew. Done. What next? Incredible. And to see the facial change going on in him is just like, it's crazy. And you realize what can be done if you have decent motivation. And I'm looking around at all these sort of slothly kids who come in expecting me to pick the bits up and make up for the work they're not going to do. And then I have a recurrence when, you know, then at the 20-year-olds, then I get a lot of 18, 20-year-olds who are coming to me and they want the treatment. You know, they're paying for it themselves, and they then focus and commit to treatment. So up to, and I'm taking now, we're opening the books to patients up to 35 years old. And we're getting people who are getting, they tend to be hyper motivated. And it's all down to that motivation. You're either under 7 or we're going to start needing motivation, quite big motivation. Even some of the younger ones, it's more motivation. But, and of course, I haven't got it perfectly worked out yet. You know, I'm trying to do that. I would love some help from the teaching establishments, from the full-time salaried staff whose job it is to help me. You know, we've spent all of this time, you know, almost afraid to say that statement. Sorry, this is true. We're paying our taxes, and the salaried professors, it's their job to listen to us, observe abnormalities that we might show, like the odd incredible result, and investigate it further. It's not our job to have to go and, you know, people keep telling me, oh, Mike, go and research, do some research and prove to me that your system's any good. It was lucky we didn't ask Einstein to do that, wasn't it? You know, oh, Einstein, on your spare time, when you're not working at the patent office, make some money to build a large hadron collider, and then you can prove it. No, they looked into what he was saying, said, well, this makes logical sense. They engaged in the scientific process and they moved forwards. And in a way, I don't know what it is. You know, even my father and all of my colleagues around me go, oh, well, you know, the professors aren't. No, the professors should be doing their job. They should be looking into this. This is really important. This is vitally important. And the idea is we have a system where we both live in relatively socialized countries where we have professors who are paid for by our taxes to look into these systems. And that's what should be happening. We need to kickstart this system so that it works. And that's one of my missions. Just get it going. Just get engagement in the scientific process from the top down. Really, there's no way that, you know, how can people turn around to me and go, oh, well, I want you to prove to me that, what? How? You know, I work as many hours as I possibly can. We're just getting profit worthy here now after a decade of literally not having holidays. You know, I've got Crohn's disease. I've got 2 children I want to bring up. I'm supposed to just work all hours God gives me to prove it to be. I mean, it is hard work, really hard work doing this. And it's not that I just get help. I get utterly the opposite. I get slapped down at every opportunity. And that is, it just is unhelpful. You know?
Do you think I mean, this is a very complex issue, as you say. It's very hard to, I mean, I remember when I was first, you know, I think it was 2016, I saw you and you know, just kind of diving into exactly what you did. it was very hard for me to get my head around all of the different things. You know, you mentioned you went to an ENT surgeon, you went to, there's a lot going on that you have to really kind of go in and think about and then consider to put all this together. Do you think that it's a very hard problem has kind of held it back, and that it's kind of that it's
yeah, in a way, and of course, again, it's coming back to that thing, is the pretty face thing. You know, we're making pretty faces. Oh, well, we're proper doctors and you're just making pretty faces. And also, it's inevitable, isn't it? You know, how many times do we have this? We hear again in medicine. You know, medicine is really good at making little course corrections, you know, going like this in an angle. It's very bad. Woo, we've gone the wrong way. Science in general is very bad at admitting it's gone the wrong way. It's set up to make little course corrections. You know, we look for the heroes in science and all people who got the A stars, and they're going to be the researchers. And, you know, people like me, they wanted to kick me out of the university. You know, they were concerned I was spending too much time in the bar, not studying enough, and not passing exams. And, you know, there, you know, I got good patient skills.
Okay? No, I've seen you. I've seen your practice. Your patients love you, and you know what? I've seen a rise in these kind of patients and some have come across your work and they've been following your work, and they are really, really motivated into this stuff, and they've read a lot. And I've got a very.
I mean, I'm really, really impressed with many people follow me. You know, I mean, guys, for all of you listening out there, it really does blow me away how knowledgeable you are, how helpful you are at telling other people, spreading this word and message. And, you know, it kind of makes me feel that I have to up my game to be worthy of the followership that I get. So thank you. You know, you are helping. And, yeah, it's useful, because I tell you, sometimes I feel very alone. Yeah. You know, as I said, Steve, the constant thing I've said to people is, I said to people, you know, you've got the establishment here, you know, the absolute standard way, and you've got all of these non-mainstream, where am I with this? It's not a mirror. You've got all of these non-mainstream people here, and then we are over here somewhere. I think a lot of people don't realize just how different we are. And our thinking is, they just assume we're not taking teeth out, non-extractionist. Well, that couldn't be. I mean, we're not really trying. It's just, if I took teeth out, I would have even more space. My problem is I end up with bags of space in mouths.
I remember seeing that some of the palates I observed in your clinic, that was one of the moments that really kind of opened my eyes. Like, this is an impressive amount of space at the back of the intermolar width that we saw.
It's not one or two, it's every single patient. This is a lot. It's like I have a breed of giant mouthed children who have good faces that come to see me. It's just, it's crazy. And, you know, the value I had Nick. Okay, I won't say his surname. Nick came in the other day with his mother, and he must be 16, 17. He's just finished growing. He's a little below me. He's a little bit upset about that. I've known him since he was 7 or something. And he is just so confident in life. You know, just exudes confidence. And he's got this chiseled jaw. Decent, not the best cheekbones, but decent cheekbones. But I tell you, a really chiseled jaw. And you pick up the photographs of when he was 7 years old, and you know, it was okay, but most kids get worse from that. And here he is, just oozing confidence. And you're thinking, I did that. I mean, it just, you know, and he goes to private school, which I'm sure helps. But, you know, I had a parent the other day who said to me, Mike, you know, the choice was you or private education. We chose your treatment. And you know what? Hands over. hands over, that was a good decision.
I mean, you think about the the connection between their sleep breathing, straight connection to how if you've a child that is 7 has a better developed airway, and that they're avoiding any kind of sleep issues, which we know can affect growth and development, then it makes sense that you may have these outcomes where these better developed young adults, because they're sleeping better. Just straight on that point. Patrick McEwen, I spoke to him a few weeks ago. He talked about his early experiences with these allergies and these terrible learning experiences he had. The pressure of trying to go through secondary and tertiary education when you can't sleep. For parents out there, it really is a very, very powerful message. If you want your kids to do well, which is every parent on the planet, right, they need to sleep and rest well. And that story that you tell really kind of it resonates with me, that you've helped this child grow and develop. So it helps them be a better person in that way.
And the thing is, Steve, I'm not finished. I'm scraping the surface. Wait till you see me really get cracking. And we've started the upwards, because the hard thing was getting this clinic open all the time with decent staff. That was my real, and getting enough patients coming to see me. It was what you do, as you said, it's very hard to understand this. So before people get their heads around it, or enough people in my local area who can come and see me, can afford it and have the motivation to do it, we were just sitting with no patients. And I had to make some life decisions. And I decided to throw my money where my mouth was and live my dreams. And it paid out. And it mainly paid out because of the people online following me and propagate. That's it. It's it. I'm a slave to these people. I owe them everything. And after that, but I was always going to do the right thing, but I'll do the right thing extra doubly do now.
Let's talk about something, because you've helped educate people about this tongue connection to palate development. So, I mean, let's talk about some of the messages that have really resonated with people as to how you change your tongue habits to potentially, I mean, there's a lot of 17-year-old, boys doing your online programs because of the idea that it gets them chiseled cheeks and jaws. So what are the principles that you found have resonated well with people that has pushed this to the point where you're being covered in the New York Times, for instance,
or stopped in the supermarket when I go to buy things? That's the most. I tell you, Steve, in New York Times, that article was. I mean, I don't think the New York Times could come to bring itself to put its finger right on the full scandal that's going on. So they tried to paint us as a bit weird with a twist at the end that maybe we're correct. One thing, I think a lot of people have got into this chewing, but I think that one of the reasons this really resonates and this message has gone so well is that there's a lot of kids who were forced to have orthodontics by their parents. They didn't really want orthodontics. It wasn't a pleasant experience. They're now forced to wear retainers that they don't like wearing. And now they find out that the whole process that they didn't want to have, well, someone basically lied to their parents, and the retainers that are now wearing are probably detrimental for them. This is my opinion. And so that, I think, it makes a group of quite angry young individuals, and kind of rightly so. This is their health, and of course, this is how they look, and this is this really sensitive age that they have, these late teens, early 20s. They realize that, someone's messed their face up, and they're having to wear a retainer they don't want to retain, and they didn't like the experience they had, and they suddenly realize, well, actually, there's something I can do about it. That makes sense. And something else, I tell you, when my job here is to change facial form. And I'm often reviewing back on the photographs that I've of patients. I literally work with a photograph in one hand of where they started, looking at the patient with you. I've done that with you, looking at these facial changes. And what I know is when you, in the cold light, the cold, harsh light of day, when you put the photographs up on a computer and you look at them, I tell you, facial change isn't as obvious on a photograph as you know it is, because you can see this person, you can see how they've changed, they've blossomed. Yet when you put the photographs up, it's not quite as good. Now, for me to see mewers whose facial form has changed so dramatically means that that's the tip of the iceberg. There are thousands upon thousands upon thousands of people who can see they look a lot better. It's not as easy to put onto a photograph. They didn't have photographs. But, you know, I don't have time to dip into the mewing world very often. You know, I wish I did. And that's something I'm trying to work toward, making more time to do these things. But what I do notice is there's some stunning results. And the mewing world has got it's got its own legs, and you know, in a way, I don't want to monopolize, take over. We are going to be doing an app because I think that we need to properly educate people, get the information out there, create a community, and to do the changes I'm going to do, change the world. I'm going to need some income from this. You know, income's always been the hardest thing. You know, life has been tough. So we're going to reduce an app, and that will be helping people. It will be a phone app. So we've done some preliminary filming. It's getting on there now, getting on with it. And we're aiming to do this as cheap as possible. But the idea is to take this further, to understand more. You know, if I can get people telling me how they got changes, we can actually make a science out of mewing. And that will help people.
One of the interesting patterns I've noticed are people posting their results of mewing on the internet. Have you seen a lot of those? A lot of people are posting their videos, a lot of YouTube. I'm not I don't really kind of venture on YouTube very much, but I see a lot of people posting their results. And, you know, you're talking, some people have gone on 6 to 12, you know, months up to years doing your program. And, you know, they're showing that how they're, you know, obviously you can see them in better posture, but also too, I know what you mean in terms of like the photos and the images don't potentially give it as much justice as what you might see in the person, especially when a person is standing up straight and breathing well, and, you know, and the face is speaking to you. You know, it goes right back to what we spoke about in the beginning, that, you know, there's this deep connection between humans when they look at each other's face. There's something about that. But there's this whole movement of people that are posting their own. And I've had patients come in that are, you know, they call themselves mewers, and it's really fascinating to see this movement moving forward. And it's great that you're you know, you're working to put it together. And, you know, we really have. Well, there's a lot of people that owe you a lot for doing that.
Yeah, well, this is kind of, you know, you get this sort of civic responsibility, and I've been forced into this position of civic responsibility that I will take very seriously. And, you know, one thing I want to do with this app is try to create eventually second generation or third generation, a marketplace where people can get return, get rewarded for sharing their ideas and helping other people. And I think that's very important, because then you send up an internal economy of people to make people better. And that's what we've got to go. You know, I don't care if the best technique is hypnosis. If that technique helps people and adds value to people's lives, then I will promote that technique. And science doesn't come up with preordained, you know, you don't, and that's the problem at the moment. You know, the orthodontists want, you know, this method or that, but they've got a structure, and they're expecting that structure to produce answers, and those people to produce answers.
Do you think this area is part of a little bit of a renaissance that we're having in terms of understanding the human body? In 2001 there was the human genome project, and then 2008 the human microbiome project, that showed that there are trillions of bacteria living within the digestive system. That's a huge spanner into what we think about, even infection theories and so forth, that the body is far, far more complex than we ever dreamed of.
Far more complex and far simpler as well at the same time.
Well,
it's fascinating to see, because of course with this human biome, I don't think it's fortunate, but I have a chronic disease. So I have Crohn's disease. So I've had to learn, I've had to really look into this microbiome thing. And, I now have I've now stabilized my weight. It went up. They gave me all these hugely calorific drinks that you could tell every time I had one of these, I felt bloated and uncomfortable. I've stopped having those. Of course, my diet has dropped back down again. And then I've got off on a sort of flat level of, I'm trying to break 67 kilos now, which someone at 183, I should be heavier than that. However, it's forcing me to look into it, and it's fascinating. But I always thought it was going to be this way. Even I remember in the 90s thinking, I bet you there's a hell of a lot of bacteria inside us that we just don't know about because we can't culture it. And I'm sure it's something to do with that's leading to the Crohn's. But it's interesting to be, in the Crohn's world and in the orthodontic world and seeing these two things slightly separately. But I think in a way, Steve, we're talking about a renaissance. We're talking about going back to some more traditional family values here. Sit up straight, elbows off the table, eat with your mouth shut, all of this stuff. And in a way, and I've noticed this when I'm at home, that if you win at the dinner table, you're in control of the house. Strange thing, that. But I'll make sure if I can get my kids, and I will tell the kids, I go, right, kids, having dinner properly, anyone messes up, I'll put you on the naughty step. You were going to sit up with your mouth closed. And you have to then take someone to the naughty step to make sure it's understood. But then, you take this interactive or confrontational situation, the dinner table, and you take this as a microcosm of your control in the house. And if you can win that, then you're in control in the house. And that, I think, there are going to be a subset of parents that are going to follow that as I evolve, and you could make a book on that or something, that you will see a subset of parents who will follow those values. I don't know how wide that will go. I don't know if we're ready to turn the thing. You remember, we go back 150 years. The Victorians were very organized. This is, it was a very structured society, but also it was a very unforgiving society. So don't be black, don't be female, don't be divorced, don't have a child out of wedlock, don't do these things. So now we're in a much more understanding society, but with less rules. Now, are we going to slowly start to cut back up, go up to where the Victorians were? And will we do it with a different flavor, being more accepting? But it's interesting how these whole fads change backwards and forwards at different times. And it's always changing.
The idea of sitting up straight, obviously, in spinal posture, and there's one area that is really or one group of people that I think really like this this kind of approach that you take to thinking about how the jaw grows are the body workers. The chiropractors, the osteopaths. How have you seen that? I mean, because that's a very disconnected world, and that's a whole other.
Yeah. Now,
how have you seen that play out?
Okay. Now, let me in 1 minute upset everyone. Okay. So I see people that go to the osteopath. Yeah. They've got body posture like this. They go to see the cops, the chiropractors, osteopaths, and physiotherapists. And if you're in America and you wondering what an osteopath is, read what everyone else in the world calls an osteopath. And people go with great body posture. They go along to see to one of the cops, and they've probably had a sports injury or something. They get repaired, they get fixed, they never come back again. They get a treatment, they never come back. Okay? Then you have the people with moderately bad body posture. Okay? They go every month or every 2 months. They're on first name terms. They do Christmas cards, and they know the family. They're the bread and butter of the cops. And they're being kept going. Then you have the people with the terrible body posture. And they go from one member of the cops to another member, to another member, to another member, trying to find salvation. What I don't see is anyone really actually putting people back together and perfect. My analogy of it is, imagine that you've got the world's best mantelpiece clock that has got primary, secondary, quaternary, and tertiary and quaternary backup systems. It's a fantastic mantelpiece clock, but it's made of plastic. And the fire's got a little bit hot, and this whole clock has gone and melted over slightly to one side. Now, what I think the cops are doing is they're making these things tell the right time. So they're going to adjust this clock so it tells perfect time. And I'm saying to them, but it's bent. And they go, oh, but it's telling perfect time. And I'm going, but it's still bent. And they're saying, oh, well, everyone else is bent. Where are we going? I don't know what the answer is, but I'm struggling for someone who is actually making people better. And I think the problem with this is that usually you go to osteopaths, chiropractors, or physiotherapists to get out of pain. That is usually the thing. And they're brilliant at getting people out of pain. You don't go to one of the cops to get perfect body posture. And most people wouldn't do it because you need such massive motivation. I had someone from the Go Clay system come and give a course here at the weekend. A weekend, not recently. And it was a good course and it was very interesting. But I'm thinking, how am I going to remember to do this stuff all the time? Where's my motivation for doing this? Well, if I had pain, that would be a great motivator. But if I don't have pain, why am I going to do it? Why am I going to remember to do it? And here is in the problem.
Do you think there's a connection between a lack of understanding of how potentially the tongue supports, the craniofacial posture and what body workers are doing that is potentially maybe a missing piece between, I
don't know. I mean, that could be a missing piece, yes, but I don't want to jump to ideas. So many people are sending me ideas. We had the people sending these in recently. They were contacting me, these sort of breathing devices you do. And they want me to feedback. Oh, did I like it? Well, I don't really know. I mean, if I tried one on myself, I need to have a lot more patience, and they're not cheap. And it's this constant, people are coming, and there's so many different ideas. And I look at the Wim Hof method, and that sounds interesting. Then I look at the Buteyko method, and it completely contradicts the Wim Hof method, and also seems, well, what's going on here? We just need to really sit down and think, and really have these. We need to engage in the scientific process. And I tell you, a lot of the non-mainstream people are really bad with the scientific process, and really bad when I try and challenge them. I see issues with science from all quarters. Now, Steve, I would really love to do some questions because, as I said, I owe all my success to my followers, all of it.
Sounds like a good idea. Yes. So, I mean, there's a lot of questions here. I'll just encourage, because we're obviously reaching the end here, for people to put their, to put their questions to Mike. Now, the one thing we talked about is the development of certain of certain development types in kids. We didn't cover the
Okay,
types
all
of
right.
malocclusions. So Tanya
we've got
asked, please address what to do with class 3 maxillary insufficiency.
Okay.
Can you quickly
All right.
explain
So
some of that?
first of all, what causes class 3? Right? So the profession believes it's genetic. But I mean, I'm sure there is some little genetic tendencies. But sorry, that doesn't make something genetic. I mean, the evidence doesn't come down that's genetic. Anyone wants to discuss this with me, open space. Now, I think what's happening is you're affected by craniofacial dystrophy. You want to better breathe well, and you want to compensate. So what you're going to do is you're going to drop your tongue down low in the mouth. And then you're going to hold the mandible forward slightly. And that's a great way of maintaining an open airway. If you try it. Great way. In fact, don't even do that. If you simply touch the lower front teeth with your tongue, sit there for a while and then try and bite together, and you'll find your jaw has been held slightly further forwards just from doing that. Well, if you do that all the time, it will grow further forward. And that is your compensating mechanism so that you can breathe properly and you've got a comfortable airway. Great. Now, what can you do about it? Well, all right. If someone is, so what do? I would take someone at 5-6 years. I haven't done any younger. 5.5 was the youngest I've done. And I would place appliance in the roof of their mouth, and then I'd put some forward pull contraption. You know, I've got the Mu Vector neck gear, we've got the Hickam. Those are the two I'd put my money on at the moment. And I would literally pull the top jaw forwards. Then let it go for a little bit, let it settle down. I'd widen the lower so to match the widening I've done in the upper. And now I've got everything further forward. It looks much nicer. Now, the problem with class 3s is if you just leave it, the result will go in time. So you're going to need some type of system, reminding system, educating system to keep this change happening fresh. So I then go to a nighttime appliance, having done that. And you're talking about 1 to 3 years of treatment. And then you're going to put a nighttime reminding appliance in them, then remind the basics, sit up straight, eat tough food, breathe out your nose, lips together, taping at night if necessary. And these are the sort of things that you can address with class 3. Now, I've just taken on a couple of class 3 people in their early 20s. And what we're going to be doing is we're going to be doing the TADs into the roof of the mouth. So those are like bone screws. And basically doing the same thing with the addition of these TADs. And the preliminary results look nice. You know, I'll report more as we go forwards. I've almost been holding cases back for certain reasons. Fairly soon we'll start pumping them out because, and you know, we don't treat that many patients here, so I don't have that many cases to distribute, but I have some really nice cases, particularly some class 3 cases. And yeah, with class 3, and I mean, but the essential thing with class 3 is get the tongue up, get the tongue in the roof of the mouth, and break this tongue to lower tooth habit. That's what I've learned relatively recently, breaking that habit. But getting good muscle tone, but again, tongue in the roof of the mouth, but you won't get the tongue in the roof of the mouth without a lot of space this way, but also having the whole maxilla forwards. So you've got space in this direction, or this, in this direction. Yeah, getting that maxilla forwards and upwards. The further forward that maxilla is from the hyoid bone, the better.
Mike, Diana asks,
why retainers are potentially a bad idea. But sorry, jumped in. Right. So why are retainers potentially a bad idea? Because they can hold the teeth out the balance zone. So imagine, okay, I remember this, and now there's this story. So we were having a big round robin male with the great and good of the non-mainstream orthodontics in Europe. And someone said, Professor Magni said he remembers treating this young boy. And this young boy had crowded lower front teeth. Everything else was perfect. He had crowded lower front teeth. So they put in a lip bumper. And what the lip bumper did was hold the lip back. So it holds the lower lip back. And it's also a little bit uncomfortable so that you don't, you try and change. You're not going to use your lip as much. But this one clearly, mainly, simply did the job for the individual. The teeth, front teeth came forward, bottom front teeth came forward, lined up so perfectly that everyone was very happy. Big round of applause. They put a fixed retainer on the back of the teeth, and then the child went. Now, about 2 years later, the mother brings the child back into the clinic. Not happy. The retainer is still perfectly bonded to the back of these lower front teeth, and the lower front teeth are in a perfect position. But the gum on these teeth has just dropped down. And all front teeth are standing there with 2-3 millimeters of root exposed all the way around. So now what's happened? Well, when you put the lip bumper on, you change the balance zone. So the teeth, the bone, and the gum all came forwards. Now you've braced the teeth, braced them, in a set position. The function has reestablished itself because you didn't change, and the bone of the gum has gone back because the teeth didn't go back because they were held with the fixed braces. And that's what can go wrong with retainers. And I see people, and actually, and this is what upsets me the most, because a lot of when I said that you've got mainstream orthodontics, non-mainstream orthodontics, and then we're all the way outside. So I'm not working well. This is it's not a mirror image, it's a real image. So either way, so we stand so far away from non-mainstream orthodontics. I think a lot of these people get a bit of a shock when I actually mention what we do. Anyway, clearly, so I know that a lot of colleagues I deeply respect are doing a lot of expansion, a lot of Damon, a lot of these other things. Okay? They're widening the dental arches, a good 4 or 5 millimeters. And then they're just putting retainers on, holding these teeth out there. And we're starting to see lots of fenestration and dehiscence in the bone. But we're starting to see a lot of this anyway. You know, I met a girl who was a dental nurse who worked weekends for a forensic dentist. So he's looking at dead people. They're trying to, when people die and you find their body, and one of the ways you can recognize them or identify them is by using the teeth. And so he's getting to see in places where most people don't. I don't get to lift the gums up of a 14-year-old boy and see what's going on, and yet he does because there's no gums left. And the girl, this dental nurse, remembers him commenting to her. He says, it's like we're a different species now, and we've got fenestration, dehiscence on the teeth. So these are the teeth broken through, the roots of the teeth broken through the bone everywhere, and these are young kids. And we're starting to see it now with adults. Because remember, mass orthodontics didn't start till, I guess, the 80s in America and the 90s in Europe, Australia, and lots of the rest of the world, what we used to call the developed world. And so that means orthodontics, the oldest people with retainers, the big chunks, are in their 40s. Well, realistically, I know myself, you can be abusive. You can drink alcohol, you can do what you want. After 40, life catches up with you. And I have a friend in the States who's a periodontist. And they said they're starting to see people coming in who are still wearing their retainers from when they had orthodontics. They get a little bit of gum disease and it runs through the mouth like wildfire. They then lose a lot of upper back teeth, and there's no ridge to put a denture on. And what's really worrying was the big expansion rather than extraction. So people weren't widening these arches. Previously, they were taking teeth out. And the real change happened in the late 90s, principally because of my father. And he caused a world change in the amount of teeth taken out. And so people are just widening these arches. And of course, they're all 10 years younger. And so they're all stored up. And I really worry about that future. Yeah, I can't tell you to stop wearing retainer. Please don't stop on my account, because what else are you going to have? And I can't be responsible for your relapse. Well, I can't be responsible for the problems with retainers either.
And the main point you're trying to make there is that there are physiological factors here that, you know, we can potentially train. They're not easy.
Not easy, no.
Yeah, not easy. And going through my own kind of journey in learning, you know, sleep breathing and so forth, it is definitely not easy. Mike, I just want to thank you so much for spending some time with us this evening. I know it's late in the UK now.
Yeah, it's late. We're in what? It must be 9 o'clock now. So yeah.
Yeah.
My kids are already in bed, so I missed that tonight.
Missed that, yeah. Look, I really appreciate you spending time, and there's a lot of people out there that love your work, and it's really been enlightening to hear your story. Tell us a little bit about what you're doing, where people can find you.
Well, I mean, yes, I'd almost say don't try and find me. You know, we already get 100 mail. I mean, you try not to send mails to my clinic. It actually it drains the staff work trying to deal with mail. You know, we don't answer questions on mewing. They're not qualified to. I don't have time to. And, you know, all of these questions we get on treatment, and the complex questions, and people send me, you know, mails this long with all, and what am I going to do with this? You know, I'm getting 2 a day. You know, sorry, you know, that's why I need to change the world. So I don't need to answer all these mails. What to do? It's, you know, really, you know, please support the Prevent Crooked Teeth campaign. I'd love to see some more signatures on that campaign. I know it's a few years old, but, you know, that's Prevent Crooked. That's what we should be doing. We should be looking at prevention. You know, we're going to be making an app soon. Great. Please buy the app. That will help us as well as yourself. You know, lots and lots of people watching this will not have enough tongue space to really get mewing. I'm sorry. You know, I'm sorry about that. But if you really struggle with the amount of tongue space, you're going to struggle with mewing. And I think the best ways around that is find a nice non-mainstream orthodont dentist. Usually I always, you know, if you want to have orthodontics, I highly recommend seeing dentists that do orthodontics. My personal observation has been, you know, that they care because they treat their own patients, and those patients come back to them, so that they're invested in long-term outlook. And they find someone who's happy to widen your arches. I like the ALF system for getting a little bit more space. But remember, for most of you, your teeth are in a safe position. If you're not wearing a retainer and your teeth haven't been held artificially, your teeth are safe. If you now start widening, you've got to change. Remember that. You know, this is all a risky business. There's risks if you don't do it. There's risks if you do it. It's not easy. And if you're going to start mewing, don't forget neck and body posture changes, because they can help you gain the low-lying fruit. Careful of suddenly going into one of these gargantuan chewing marathons. I see people who end up with jaw joint problems. You know, I do a thing on how to check whether you've got jaw joint problems, but be careful, because you can get into a hole that's very difficult to get back out of if you've been really working on your jaw joints, overdoing your jaw joints, and you have problems with it. But I'm really wanting to cut new ground here and help all of you who have got problems. If you want to support me through Patreon, great. You know, we need someone to, and it really does help. You know, Patreon's fully sponsoring the video team now, who are really being responsive. They're getting things up there. We're coming up with some new ideas, and that's really, really helped.
What
And
is
of course,
the Patreon link that people can find?
I think it'll be on the YouTube.
YouTube. Yep.
Yeah, I mean, I'm not the best at self-promotion. Lucky I've got lots of people that help me, and that has been very lucky. But I give a real big thank you to the people who support me, and hopefully we can do some more of these sometime and take more questions. Steve, thank you very much for interviewing me.
Mike, really appreciate the time and all the work. And yeah, I look forward to speaking more. It's exciting and important work.
Yeah, it is exciting because we're making headway and we're getting somewhere. And of course, come November, I'm going to have this little court case that should that will sort the men from the boys either ways. And hopefully we'll see some truth come out with that.
It will. And look, for you, it's been 3 generations, so it's been coming a long time.
Yeah, it has been. And I would love one of my deepest desires is to get my father some of the recognition he deserves before he either dies or loses his marbles. And, I'm worried he might not get his driving license renewed. And, these hassles in life, Steve.
Yeah. Well, all the best to John and his health. Everyone's pulling through for him, and look, we hope that the family is well and everything goes well. Mike, thanks very much again.
Thank you.